Hello and welcome to the Neurophilia podcast. I am your host, Nuber Goyle, a fourth-year medical student at the Northeast Ohio Medical University. Neurophilia is a new medical podcast show focused on neurology. In each episode, I, along with top medical experts, will engage in interdisciplinary conversations to connect neurology with other fields in medicine. If you are a medical student who desires a clearer understanding of clinical neuroscience, a healthcare provider who wants a fuller appreciation of how neurology relates to your practice, or just someone who finds the brain cool, then this podcast is for you. With each episode, we hope you develop an appreciation for, and perhaps even a love of, neurology. To kick off the first episode of the Neurophilia podcast, we will be discussing the topic of neurophobia, its epidemiology, etiology, and what neurologists can do to combat it. To accomplish this, I have with me three experts in the field of neurology, Drs. Blake Buletko, Ahmed Itrat, and Michael Kentris. Dr. Blake Buletko is a vascular neurologist at the Cleveland Clinic. He completed his residency and fellowship training at the Cleveland Clinic and was the former medical director of their mobile stroke program. In addition to his clinical responsibilities, Dr. Buletko serves as an assistant professor at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University and is the current program director of Adult Neurology Residency program for the Cleveland Clinic. Dr. Ahmed Itrat graduated from Aga Khan University of Health Sciences in Pakistan, followed by his neurology residency training and vascular neurology fellowship at the Cleveland Clinic, which he completed in 2015. He is currently a staff neurologist with the Cleveland Clinic and serves as the medical director of stroke at Cleveland Clinic Akron General, along with serving as the lead for neurology education. His interests include clinical research on stroke mechanism, as well as quality improvement initiatives for stroke. Dr. Michael Kentris is a neurologist in Youngstown, Ohio. He completed his residency at Wright State University and a clinical neurophysiology fellowship at Vanderbilt University. He has helped develop and been one of the primary narrators for the Journal Continuum's Read Aloud program, as well as recording his own medical education-themed podcast, The Neurotransmitters. Drs. Buletko, Itrat, and Kentris, it is truly an honor to have you here on the Neurophilia podcast. Thank you so much for your time and participation.
Thanks for having me.
Thanks for being here. So I wanted to start by talking about neurophobia. So what exactly is it? Neurophobia was first defined in 1994 by Dr. Josefowicz in his JAMA published article titled Neurophobia, the Fear of Neurology Among Medical Students. Dr. Josefowicz defined neurophobia as the fear of the neurosciences and clinical neurology that is due to a student's inability to apply their knowledge of basic sciences to clinical situations. Since its first description, the causes and impacts of neurophobia have been studied worldwide, including the US, UK, Ireland, East Asia, and the Caribbean. The first major US study to explore the prevalence of neurophobia was performed in 2010 by Dr. Zunchuk and his team at the University of Connecticut School of Medicine. The study consisted of 152 third and fourth year medical students and internal medicine residents. Of 8 different specialties, knowledge regarding neurology was the lowest and one of the most difficult disciplines to learn. Moreover, participants had the least confidence when assessing, diagnosing, and treating patients presenting with neurological disease compared to other fields of medicine. Another study performed in Singapore by Dr. Kam et al. In 2013 determined the prevalence of neurophobia to be 47.5% in medical students and 36.6% in resident doctors, respectively. The commonly cited reasons for neurophobia are complexity of neuroanatomy, limited exposure to neurological patients, and insufficient teaching of neurological material. So as you can see, neurophobia is a complex phenomenon experienced by the global medical community in various stages of training. And with this understanding in mind, we can now move forward to discuss how we can combat neurophobia. So, Dr. Buletko, the first question I have for you is, how can you make neuroanatomy less Byzantine without oversimplification?
Nooper, thanks for having me, and glad to be here with some of my colleagues. So we're all very excited about your undertaking of this podcast. And I think just to start off with, having students like you to hopefully stomp out neurophobia and really have a love for neurology is really enlightening, and it makes us all more excited about what we do. So thank you for doing all of this. With regards to your question, I think that if I had to answer, then I think everyone would love neurology, and everything would be much easier on all of us, and neurophobia maybe wouldn't exist. So whenever we talk about neuroanatomy, it's very complex. I think that part of what we need to do is we need to potentially pause and take a moment to appreciate the complexity of neuroanatomy. I think that if you approach it in the sense of thinking that it's going to be something that's easy, or something that's not complex, or something that won't make you think or spend some time on, then you're going to set yourself up for very little success in trying to understand it. So whenever you're trying to think through neuroanatomy and trying to not oversimplify it, I also think that it takes an understanding of your learner. There are a lot of different types of learners, and there are a lot of different levels of learning that happen. So we've talked a little bit about neurophobia and how it was described in medical students first and foremost. But I think that this is true not just in trainees or students, but I think it's true with staff physicians. I think it's true with other medical professionals. And so I think it's taking an understanding of what level of learner are you dealing with, and how does that person learn best. So, fortunately, neuroanatomy doesn't change all that much day in and day out. Certainly, there are a lot of complex variants, which you can really get into some intricacies. And neuroanatomy by itself is fairly complex, but learning it, I think over time, is something that needs to be done. I think a lot of us go into neurology because we are lifelong learners. This is not something that you can learn during a preclinical course in medical school. It's not something that you can learn sometimes over the whole course of our career. So I think understanding the complexity, having a love for the complexity, recognizing that this may take time, and then also thinking of what type of learner am I, or as an educator, who am I teaching, and what is my learner do to best advance what they're trying to understand. And we're very fortunate in today's world to have podcasts and to have technology that really supports our understanding of complex ideas. So I think that having resources, different visual resources, audio resources, some people learn by repetition. I think understanding your learning style and then looking for different resources and having resources at your fingertips can really make learning neuroanatomy a little bit easier. I think if I take it one step further, it's connecting it to something that might be a little bit more tangible. So even in preclinical years, even if you don't have a clinical correlation, learning through cases or learning through something that may be more relatable when it comes to neuroanatomy, I think is a very popular way to try to understand neuroanatomy a little bit more than just trying to copy down some figures from a textbook. So I think all in all, it's a very complex thing to try to teach. I think that there should be some recognition in the complexity and some value in the complexity, and learning that this may take time. If you just kind of put this all out there right off the bat, it could be quite terrifying, to be honest with you, for a lot of people. And so I think that there needs to be realistic expectations going into what the learning goals are from a neuroanatomy standpoint. Some people you may have to oversimplify, and some people might be more ready for some of the complexities of neuroanatomy. So I think taking it in mind that every learner is a bit different, using a lot of the resources that we have in today's world to really speak to a lot of the different type of learning styles, and then having people who are excited and passionate about teaching it are all ways that I think that we can make neuroanatomy a little bit less complex, or at least able to digest it a little bit easier without making it too simple and losing that really beautiful aspect of why neuroanatomy is so complex.
Absolutely. Well, I think that was a wonderful response. And, as you said, you have to stay up to date with the times, and every single field of medicine requires you to be a lifelong learner. But I feel like the neurology aspect of it, although, as you said, neuroanatomy doesn't change over time, we should try to adapt the new modalities we have at our fingertips, such as podcasts like this one that we're creating here today, to hopefully help students and resident doctors and attendings get a better grasp of the material going forward. So thank you for that response, Dr. Buletko.
Of course.
So the second question that I have is for Dr. Itrat. One of the most reported reasons for neurophobia is limited exposure to neurological patients. However, neurological disease is often a primary cause of hospital admission or consultation. In 2011, it was reported that nearly 100 million Americans were diagnosed with neurological disease, and this number only continues to rise with our aging geriatric population. So, Dr. Itrat, what are the reasons behind limited neurology exposures, even in the overwhelming presence of neurological disease?
Thank you, Nupur, for having us on this forum. And that's an interesting question, and it speaks to this paradox where, despite increasing patient population, people still complain that there may not be enough exposure to neurological patients. And some of that potentially goes back to early years in medical school, where if you have that initial impression where neurology is difficult or neuroanatomy is tough, that sets the mode for what's going to transpire after that. Once you create that initial impression, whether that's made when the student is, going through basic neuroanatomy or the way it's being taught. If there is one student that has a bad experience or they find it tough, the word spreads pretty quickly. And that tends to be the impression overall that, that this is going to be tough no matter what. So, and then, of course, the rotations themselves, oftentimes the neurology experience is considered an elective and may not necessarily be a core rotation. So there might be many students who may not experience, core neurology at all during their medical school, rotations. And then when they do have a rotation, the question comes, what kind of exposure or experience they're having? Is it a meaningful, practical experience that they're having when they're rotating through their neurology, month or week? Or are they coming across, different experiences where, they are being asked, questions which may not necessarily be very relevant from a practical perspective? I know for a fact, historically, neurologists are known to be, known to get involved into semantics, so they ask a lot of questions about, what do you call this particular reflex, or what are the 55 names of this particular, examination findings. So how much of that is relevant in today's time, when a lot of what we do is based on, coming up with that diagnosis, a lot of it is based on, how quickly you get to the answer, how quickly you treat somebody. So I think all of that sets a tone where the experience for a medical student would be less than meaningful, and that carries over into the future experience as well. Once they're a resident or a fellow or a physician, that doesn't go away, because the ideas and the experiences that you carry over from a medical school, they're very, very strong, at that time period. I would say that there's also additional onus on neurologists, where, if there is, they have to do clerkship, directorship, or they have to be involved in creating their curriculum, how much time are they being allowed to do that? How much time are they able to dedicate so that they can construct a meaningful experience for the students? These days, it's difficult to have that kind of dedicated time, for physicians themselves to do that. So oftentimes that can be, another factor that goes into that less than optimal experience for the medical student. Lastly, I think I would also mention the fact, even when going, into field as a full-time physician, if it's a non-neurologist, there's a lot of reflexive neurology consultation on any issue that relates to the brain. So it's just that carryover effect where the physician may not necessarily think about doing an initial investigation into neurological, issues at first, but rather than just reflexively consulting a neurologist and letting the neurologist deal with that. And we as neurologists probably do a poor job where we don't, we do our work and we just either sign off or just, wither into space and not really communicating, with the physicians and educating them about what the actual problem is or what could be done. So I feel that there are several factors there that can be, attributed to why people feel that there's less than optimal neurology experience.
Absolutely. I think that is such an honest and reflective response. And it actually is a great segue into our next question, sort of this idea that physicians are, overworked and they have a lot of clinical responsibilities. So to balance that with being an excellent teacher can also be difficult. And that's seen not only on the side of the educator feeling like they don't have the opportunity to educate the way that they would like, but also in the realm of students not feeling like they're getting the sufficient teaching that they need to feel confident when it comes to the neurosciences, both in a academic standpoint as well as clinically speaking. And so, one of the other most reported reasons for neurophobia is this idea of insufficient teaching of the material. And so, Dr. Kentris, what are the most successful ways for students to incorporate the academic neurosciences with clinical neurology?
So it's, to Dr. Buletko's earlier point, you can't practice neurology without at least a basic understanding of neuroanatomy. So unfortunately, that does prove to be a stumbling block for some people. And, while orienting the initial instruction towards clinical aspects does, I think, maintain interest. Otherwise, it does become very overwhelming just from a sheer detail perspective. But taking that and applying it to someone, in the wild, so to speak, is where I think a lot of people stumble. And I had a conversation with Ethan Meltzer, who wrote, which I love the title of this book, How to Think Like a Neurologist, which I've been recommending to all of my students on rotations. And the first chapter is literally kind of like what we're talking about. It's like, how do I think about this? Like, how do I create the framework for approaching these patients? And then taking that basic science understanding of like, well, it's such and such complaints that localizes to these possible locations based off of this timeline and the associated other comorbidities. I can create a nice framework and differential diagnosis and start kind of working through the differential in terms of like your, can't miss diagnoses and your like most likely diagnoses. And in the grand scheme of things, avoid missing most things and getting to a diagnosis, maybe not the most efficiently, but in a fairly timely fashion, even with very basic neurologic skills. So, I always like to say, like, what I do isn't really that hard. Mostly I'm just talking to people and asking questions. Neurologists, for the most part, aren't proceduralists, with, obviously exceptions being to our IR colleagues and ICU colleagues. But a lot of what we do is just taking a long history and then, working into that, our physical exam to help refine our localization, which I was kind of interested. If people aren't familiar with the Bedside Rounds podcast, I would recommend that one as well. He talks a lot about different epistemological aspects, and he says the physical exam is a procedure. I was like, well, I guess that kind of is true, right? We go into it with a certain hypothesis that we want to prove or disprove, as it were, and kind of synthesizing all that information together. And I think that in most classic neurology, that's a lot of what we're doing, where you're just, again, ultimately, like so much of medicine, it's pattern recognition, but identifying those patterns is kind of the crux of the application of that basic neuroscience into a clinical framework. And having someone to guide you through that process is very important, because it can be very daunting. And like Dr. Itrat also mentioned, I think I saw a study, for the new Neurology Education Journal, which has been like fantastic for the last couple of issues. I think they mentioned somewhere like between 30-ish% of medical schools don't have neurology clerkships, which it's a huge percentage. And so, like, I know I'm a DO graduate. A lot of DO schools don't necessarily have neurologists even on staff. And so you kind of have to seek it out. So if you already are intimidated by it, you're not necessarily going to go looking for more of it in many cases. So it does become this kind of like aversive feeling to neurology. I had one of my attendings always, said just exactly like what Dr. Itrat says, like, it's a brain problem, call neurology. It's this black box, that we cannot peer inside. We have to call them to kind of do their auguries over it and decide what's going on. And it does become this reflexive thing. It's like, well, the patient's, very sick, and they're confused. It's like, well, it's because they're very sick. So sometimes you're not adding that much, but you are providing reassurance to the clinical team. And there usually is something for us to provide, even if, as a consultant, it does become somewhat burdensome from time to time. But, it's always best in everything in life to approach it with a generous spirit, and just know that people are seeking out your opinion because they are uncomfortable, or they think something is wrong and they're not quite sure what. I'm sure we've all gone to consults that we thought were going to be kind of nothing remarkable, and then we get there and like, oh, this is actually a big deal. And unfortunately, you're never quite sure unless you don't go and do the work. And so I know I veered off topic somewhat from your original question, but I think giving students that framework is going to carry into being residents, fellows, attendings. And so making sure that we as instructors take the time with medical students, which is, as I'm sure Dr. Buletko can say, it's not a traditionally compensated part of an academic position in many centers, although I think that's shifting from what I've read in recent years. But it is something that you have to like volunteer for and spend additional time on, in addition to your clinical duties or academic, research duties. And it can be hard sometimes, especially if you're not at a larger medical school or an academic center, to get that exposure if you don't kind of seek it out. I'll stop my answer there.
Well, thank you so much for that response. And I think what you said was so applicable to the situation. And when you were speaking about your own personal experiences of having the difficulty of getting that neurology exposure, I was relating to it severely, since, as Dr. Buletko knows, being an alumni of Northeast Ohio Medical University, as well as a lot of other universities in the US, exposure to neurology is limited, and we need to have avenues as well as educators that are willing to put in the time and effort to help students get to where they want to be. So I just want to take a second to thank all of you, as you've all been, a part of my journey along the way. And I've learned so much from each one of you. And so it's just a testament to how important it is to have passionate and involved educators when choosing a career path in medicine. But to shift gears a little bit, I wanted to talk about another article that actually Dr. Buletko brought to my attention, where, we earlier in this conversation, we've been talking about neurology, and its complexity and how that can be very off-putting for a lot of individuals. But sort of paradoxically, even though this information is often complex, we sort of can't get enough of it. And so there was an article published in 2012 by Dr. Durant Fuller titled Neurophilia, A New Fascination for Neurology, a New Syndrome. And that found that even in the presence of neurophobia, medical providers are still extremely interested in clinical neuroscience. And this has been supported because neurology is the most reported specialty in terms of published BMJ and Lancet case reports relative to its burden of disease, which is only about 5% per that article. So Dr. Buletko, what is it about neurological disease that is innately so fascinating?
Yeah, I think if you ask a neurologist this question, we could probably have a whole series of podcast episodes on why we all love neurology so much, and you could probably get a very wide variety of answers. I think some things that stick out to me, if you take this really complex world of neurology and this kind of brain, mind, behavior, how does it all intertwine? It's still, I think, as Dr. Kentris said, a little bit of a black box. We don't know. And I think that there's some fascination in the unknown. There is some fascination in complexity and intricacy, and it leads to a lot of really great academic discussion. I know that there's a lot of discussion within medicine as a whole. In neurology, I know that some of us are portrayed as kind of putting on our bow tie, sitting back in a big leather chair and just thinking, and never really coming to a conclusion or to a meaningful response for a patient. I think that a lot of us that do what we do know that it's different than that, but there is some truth to what's being said. And so there is some fascination in trying to understand something that's very difficult to wrap your head around. I would also say that some of the fascination and what I see being involved in a residency program and watching, kind of the growth of students to residents to fellows to then full-fledged neurologists, is that we have such a wide variety of subspecialties. I think that there's over 30 different subspecialties of neurology that are reported within the last year or two, and that's just really remarkable. I've always said, what other fields of careers can so many different type of people go into and be happy? Just as medicine in general, you can take so many different personalities of people, so many different people with different career objectives, and we're all in the same career. How amazing is that? And then if we narrow that down even more to neurology, you have the same thing within neurology. You have so many different personalities of neurologists. As a stroke neurologist, I guarantee you that my personality is going to be different than perhaps a neuromuscular neurologist or a headache neurologist. And I think Dr. Itrat and Dr. Kentris doing a lot of inpatient work, very different than someone who's sitting in the office. And so I think it's really almost magical that we can take so many different people with so many different interests, but all a common interest in this complex, unknown kind of brain and the interaction the brain has with the mind and the body. And if that's not magical and if that doesn't make you think and want to be a part of that, then I don't know what does. I'll further it by saying that we're storytellers. Neurologists are storytellers. We can't understate the history enough. And what patients, I think, want from us a lot of times is to be able to have somebody who's going to listen to their story. And so the fascination isn't just within the disease itself, it's within that humanistic interaction that we have with our patients, to where we actually have a chance to go and listen to different complaints that nobody can figure out, that somebody just wants to say, somebody wants to be heard. And we're storytellers. And by being a good storyteller, you have to be a good listener as well. And so I think that there's some fascination in that part of it as well. And I know that you're probably going to ask me a couple more questions related to this article. And I thought that the article was beautifully written. And part of the article mentions the very popular show House, which a lot of us are very familiar with. And they actually did a little bit of a dive into the diagnoses that they presented on House and said that about 27% of all diagnoses were primary neuro disorders. And I would argue that I actually went, after I read this article, and I looked at every single diagnosis that was made on House over the first 8 seasons. And what I noticed is the 27%, those were primary neuro disorders. I can't even begin to tell you how many have almost this end organ damage due to a systemic complication that leads to neuro disease also. And so I think that the fascination becomes whenever it changes who we are as people, when it changes our outward appearance, when it changes our approach to a conversation because something neurologic is affecting us, other people see that more outwardly than if something is going on kind of beneath the surface. And I think that there's something that draws people into neurology still because of all of those things.
Absolutely. And so my follow-up question to that is, how do we reconcile this fascination, this innate fascination that people have with this growing fear for neurology?
It's a good question. And it's one that I think a lot of people think through quite a bit. And how do we combine the two to come up to some happy medium where a lot of people can enjoy neurology or at least feel comfortable with it? To be honest with you, in thinking through that, the best answer I believe I can come up with myself, and I'd be curious to know what my colleagues think too, but I think that you have to know that there's limitations. And I think that there's a lot of power in saying that you don't know. And I think sometimes we shy away from that and we get fearful as medical professionals because of the standard that we're held. And we're supposed to be experts in our field and we have to know everything about everything. That it's okay to say, I don't know. And going into neurology, I think that there's some empathy, there's some power, there's some compassion. I think that there's a very, people call it the gray area, but I think it's not necessarily gray. It's maybe that we don't know yet where we are in that area, but I think it's okay to say, I don't know. And so if you have some phobia, but you also have a love, I don't think that you have to not be scared of something to love it. I don't think that you have to know all the answers to be able to feel like you're an expert in something. And so I think a kind of open arms, kind of encompassing the I don't know and being confident with what you do know and what you don't know, and also being able to relay that in a way to patients to where you can tell them that you don't know, but that's not the end of the line. That just because you don't know something doesn't mean that you won't continue to try to figure it out, that you won't still be there for them. I think patients, one of the worst things that they want to hear is there's nothing more that I can do for you. And so there's always something that we can do for our patients. There's always something we can do for our students, our residents, ourselves, our colleagues. And so I think saying I don't know can be a very powerful tool in combining the unknown and the phobia part of neurology. But then I don't know, but I'm going to go and try to figure this out. I'm going to continue to advance our field in ways that at some point in time, I hope that we have an answer for what we don't have an answer to now. And I think if you put those two things together, it can be very, very powerful.
Absolutely. Dr. Itrat or Dr. Kentris, would you like to elaborate on what Dr. Buletko said?
Sure. I can't count how many times in a week when I'm working in the hospital, I have to tell someone like, I don't know exactly what this is, right? And I had occasion to revisit some of the classics this last year, as so many people did during COVID. Old interests resurface, and I read Plato's Apology, which like kind of like the famous, or I should say, one of the famous lines, to paraphrase, is the only thing I know is that I know nothing. And it's like the more we learn, every like this deluge of information coming out constantly in the neurosciences, and how that affects like diseases that 10, 20 years ago were like essentially terminal diagnoses, and now they're like, well, maybe we can treat that with gene therapy, or all these remarkable technologies that didn't even exist. And certainly not in a clinical perspective, even just a decade ago. So things, the window keeps shifting in terms of what we do understand, what we can do. Some of my older colleagues, when they would diagnose someone with multiple sclerosis back in the 80s, it's like, well, you're going to be potentially in a wheelchair within a decade, and there's nothing we can do to really slow it down. And now we have, obviously, that is not the case anymore for many people. And so we're seeing this expansion into all of these previously thought to be incurable, intreatable diseases, and identifying more and more with more and more granularity, like what the underlying pathology is, and all of these things that, unfortunately, to the the clinical eye might look very similar. And then we find that there's different underlying processes, and we can, it's very much getting into the era of like sort of designer therapies for many of these disorders. And it's both terrifying in as much as we think we know things and then we are proven so completely wrong, and amazing in as much as like there are treatments to being developed for all of these terrible disorders. So it's certainly an amazing time to be a neurologist, I would say.
Absolutely.
I would just briefly comment, one of my pet peeves here is, oftentimes where we have this grab bag category of diagnoses where we try to just fit in whatever we have into those. And oftentimes, that leads to actually, a suboptimal experience for the observers or the students around you as well, because, you're trying to justify something when it doesn't meet, what you were expecting to see with this particular, diagnosis, and then you're trying to justify and fit into that particular diagnosis. So I completely agree that at that point in time, saying, I don't know, but we can, work on it and try to figure out, is the best approach, I would say, in those situations.
Absolutely. Well, thank you three for commenting on that. And it's also a great segue into our next question. Something that Dr. Kentris said was this idea that the future is bright for neurology, yet although there's a lot to be discovered in terms of therapeutic modalities, as well as these new pathologies in neurology, we are still having a difficulty getting people into neurology in terms of the number of applicants and the overall shortage that we are facing as a country when it comes to neurology physicians. And so according to the Association of American Medical Colleges, there has been a 52% increase in neurology applicants since 2018, but the demand for neurologists still outweigh the supply available. And there is a predicted 20% shortfall of neurologists by 2015. So Dr. Itrat, besides neurophobia, what are other factors that contribute to a neurology shortage in this country?
Well, I would like to take some solace in the fact that there is an increase in the number of applicants, which we always feel like isn't happening, but if we have statistics to back that up, then that's a good thing. I would also preface that the number of referrals, or not necessarily diagnoses, but need for neurologists is also increasing because the increasing number of testing, compared to 20 years ago, obviously imaging was not what it is now. And, there are much lower thresholds to order an MRI, on patients. And oftentimes there are incidental findings which lead to neurology referrals. So I think in terms of the need, when you look at the need and the growing need of neurologists, I think that is part of that equation, that where that need for neurologists is coming from. But at the same time, I think a lot of this goes back to what we discussed previously, where when it's a less than meaningful experience for medical students at an early age, and that may not necessarily be because of neurophobia, but just because people are not really enthusiastic about going into neurology, I think that would lead to a dearth of neurologists down the road. There's limited preclinical exposure to clinical neurology, where all you're doing is basic sciences, and instead of focusing on diagnoses and treatments, a lot of stress is actually kind of put on just core neuroanatomy, which I'm not saying that is not important, but at the same time, I think the way to teach that is using a diagnosis-based or a disease-based model, and then teaching neuroanatomy in that context rather than just teaching neuroanatomy as a dry subject. Oftentimes it's going to be more helpful. Neurology as a practice is also something that is relatively less glorified, I would say, as opposed to some of the other specialties. I know Blake mentioned about House, where, I think that's one show where I guess it is a bit glorified, but at the end of the day, House is not a neurologist himself. So so there are, there are specialties which are more procedure based, obviously, which are oftentimes a great pull or trigger for, students and trainees to grab on and like the idea of going into those kind of professions. Examples include, obviously surgical specialties, cardiology, gastroenterology, all of those are very, heavily procedure-based, specialties. So that could be one part of the reason where, while in neurology, there are, areas where there is procedure based specialties like neurointerventional, neuro-ICU, EMGs, and things like that. But as a whole, when somebody thinks about a neurologist, generally they're thinking about somebody who's seeing patients in the office. And I'm not doing a lot of these procedures. So I feel that kind of oftentimes is another reason, and that's just the basic, understanding that a lot of people have. I don't think we can have a complete conversation without mentioning pay, so compensation wise, if you look at the, top 20, 25 specialties within medicine, neurology is not among the top 10, according to most surveys in terms of their compensation. So that's one additional factor. When you combine the underlying, difficulty with the topic itself, and looking at, something which has relatively less procedures, and then when you combine that with, where people say, hey, it doesn't pay me that well, then that definitely adds to that kind of exodus, so to speak, of students away from neurology. And again, expanding those points about, when people think about neurology or neurologists, they tend to think that they're people who diagnose but don't treat, which we know as neurologists is definitely not true. There are treatment options and there are management options available for essentially all diseases. So it's not just the actual, pill or the pharmacological agent that you have to administer, but there's so many things beyond that require a neurologist, and there are things which only a neurologist can do, which other specialties or other, members cannot do. And then, just talking about treatment options, as Dr. Kentris had mentioned, that things like MS, for example, we did not have a lot of treatment options back in the 80s, but look at now, where we have 20 or so, readily available, treatment options for patients. We have expanded the use of, antibody or targeted, agents specifically for MS, and antibody targeted treatments for migraines. There are genetic treatments that are available. So it's definitely changed, in that spectrum over time. So I think, but just the opinion and that knowledge may not be commonplace. So all the more reason why stress on disease and management earlier on in the medical school curriculum is one key in this situation. So.
Absolutely. And while we can't necessarily change the compensation or the other factors that neurologists struggle with on their way to becoming excellent physicians, one thing that we can discuss and possibly help to fix is this prevalence of neurophobia. And so, in your opinion, Dr. Kentris, what is the most effective way to eradicate neurophobia?
So before I jump into that, I will say, to Dr. Itrat's point about pay, it is currently, I think, the second most in-demand specialty. So if you are going into neurology, don't be afraid to negotiate your contract, because they need you more than you need them. But with respect to neurophobia, I think a lot of what we've talked about so far in this conversation are kind of the ways, the best way to fight something you're afraid of is to become more familiar with it. In terms of what like clinical neurologists should be doing is taking an active role in, be involved with your local medical school, take students for rotations, get people that hands-on clinical experience to familiarize themselves with neurology and the practice of neurology, even more importantly, if they're not going into neurology. Obviously, if you're going to do a neurology residency, you're going to get exposure, but for the people who are going into like internal medicine or family or some other specialty altogether, this might be the only time in their career. And I think about where I am now. Previously I was faculty at Wright State, and I had a neurology residence and a clerkship, and we moved closer to family, and so now I'm like one of the only neurologists in a 50-mile radius. And it's obviously much different in terms of not just the neurology knowledge of the exposure of the students, but also the faculty and the other attendings in the area, right? They're used to the neurologists who've been here for 20, 30 years. And, you kind of wind up in a little insulated bubble per se in terms of some of the practice. And so not just educating students, but also the residents, if they're willing or even unwilling to do rotations with you, and the faculty. I always think, while nobody likes documentation, I always think the classic reasons for writing in general, right, to inform, to educate, and perhaps even in the medical record to delight. But the every interaction is a potential opportunity, for spreading the gospel of neurology, potentially. So I think approaching it with that perspective, which it can be hard when you're feeling tired and run down, but trying to be that, reach for that ideal neurologist in your mind and try and aspire to better practice. But I think just always being willing to discuss things, to talk through things, not being the kind of like the old stereotype of, the very short, brusque attending who's like, well, why are we doing this? Because I said so, right? That doesn't help anybody. And in reality, even if you just approach it from kind of a rational selfishness perspective, they're just going to call you again. So why not explain it now? And hopefully educate people so that, maybe you are in an area where there aren't enough neurologists, but educating your hospitalists and PCPs in the area might help with the quality of the referrals or the workup that's been done before the patient shows up in your clinic. So I think approaching it from all these angles is important. And, like Dr. Buletko mentioned earlier, we do have, venues like this. We're able to do, lectures, asynchronously, teleconferences with people like across the country. So there's so many ways that we can become involved with education. I know for the last 2 years, I've been doing a lecture series for the psychiatry residents in Akron. And, I haven't driven through Akron in probably 6 months, but still, it's something that we do. And, we do see like there's, their in-service scores go up in the clinical neurology section and things like this. So, it benefits us all to know a little bit more about the areas that we interface with on a regular basis. So I think making that effort to reach out to look in your community where the areas that are deficient, where are you seeing the problem referrals coming from, and reaching out to those areas like, hey, I'd love to do some, talks with your residents or, with faculty or, which, can be hard. You don't want to offend anyone's pride, but I think if it's given in a good spirit, it usually is received in such as well. So I would say that's kind of my approach to it, at least.
Absolutely. I think that's a great approach. And it goes back to that saying of, you can give a man a fish, but if you teach him how to fish, the results are a lot more beneficial. And so thank you for that insight, Dr. Kentris, and Dr. Buletko and Dr. Itrat. I wanted to broaden this question to also include the two of you. How are you guys accomplishing this task of trying to eradicate neurophobia in your own medical practices?
So, I can start first. basically just kind of laying out a sort of, in basically your own mind, what kind of a setup you want, or what kind of the core kind of disease or diagnoses that students who are rotating on the service, or the rotators that come on your service from other specialties like internal medicine, what I tend to envision is, what are the things that they're going to encounter, even if they don't go on to become neurologists, down the road. What are the core skills that they would need, from that perspective? So, having that set of diagnoses like, headaches, strokes, tremors, seizures, obviously, so some of the common things which I would like them to be empowered to treat, or at least initiate their basic, management, or develop a plan. And then obviously, if it becomes more complicated outside of that, then they can refer, to a neurologist. I think that's basically my sort of, way to approach things. So having a sort of a core curriculum around those things, and making sure that whoever comes on service gets enough exposure to that variety of diagnoses. Again, I don't necessarily want them to be seeing, things that are very rare, again, although we see those, but, that's good from an academic perspective. But I think overall, asking questions and bringing up, conversations about common things and how, you would diagnose, and what are the uncommon presentations of common diseases or diagnoses, and then kind of working on, developing a plan and management strategies for something like that. I think that's the approach that I usually take in terms of ensuring that they remain focused and interested, and again, down the road, they're able to use those practical skills. And then obviously, if there's medical students like you who are more interested, then, obviously the discussions and conversation is slightly different, as you know. So, but definitely something that we want to look at the broader picture here. So.
Yeah, I can't agree with everything that's already been said. I won't add too much, but I have a couple maybe thoughts that might tie some of this together in an unconventional way. One, I think that we need to implement a pyramid scheme. It's as simple as that. And what do I mean by this? If I can light the neurology fire in 2 people, and both of those 2 people go and light the neurology fire in 2 or 3 other people, then all of a sudden we have this kind of sweeping model of kind of invigorating neurology and this neurophilia into people more than neurophobia. Neurophobia happens in the same way we talked about that earlier, where one person says, oh my gosh, neurology is so scary and it's so intimidating and it's so complex, and I didn't wrap my head around this. And then they spread that to the next class and the next class. But where are the voices of people who love it? Where is the neurophilia at? It's out there. It's been published on. You're doing a podcast on it. We are all here. I think that it just takes reminding people that, I love what I do. I would not change anything about what I do. I love being a neurologist. This is a childhood dream come true for me. And this is something that is a big part of who I am. And I think nowadays in medicine, with medicine changing, in the field of medicine changing, change isn't always bad. And I think we always focus on the change that may not be the most positive. But I think we as neurologists need to remind people that we love what we do. We love storytelling. We love the advances that are being made. And I think if we can share what we love about neurology more than what we can do to continue to facilitate this neurophobia with all the resources that we have, I think that that's how we eradicate neurophobia. I think it's being patient, knowing limitations, setting expectations with learners and understanding your learners, and then reminding people that we love what we do. We love coming in contact with people who also love neurology. We're a very small community, and even as faculty, attendings, we all rely on each other. We are all very collegial and collaborative, and I think that there's something to be said about being in a community that really works together for similar goals. And so if we can spread that more so than what the neurophobia gets spread, then I think that we're doing everything that we can.
Absolutely. Well, I just want to once again thank all three of you, Dr. Blake Buletko, Dr. Ahmed Itrat, as well as Dr. Michael Kentris, for taking the time to provide such insightful perspectives regarding the topic of neurophobia as well as neurophilia. I'm sure that our listeners will learn so much from this episode, as I know I have already. And if you are hearing this message, you have listened to the entire episode. And for that, we want to thank you from the bottom of our hearts. We hope you enjoyed this episode. And if you did, please leave us a review and share this episode with a friend. Make sure you follow us on our social media at Neurophilia Pod for updates on future episodes. See you next time.